on the line Dr. Kanta Ahmed. She's a pulmonologist and intensive care specialist currently treating COVID-19 patients in New York. She's an associate professor of medicine at the State University of New York in Stony Brook and a fellow of the American College of Physicians, as well as the American College of Chest Physicians, and a fellow of the American Academy of Sleep Medicine. Dr. Ahmed, thanks for joining the show. Really appreciate it.
Ben, thanks for having me. And I'm now affiliated with NYU Langone, but I'll just speak about what we're seeing in New York generally.
That'd be great. So what is happening in New York? It's hard to tell, honestly, from the media reports how bad things actually are. You're seeing some media reports suggesting that the hospitals are completely overwhelmed, that there's a shortage of ventilators and medical equipment. And then you're seeing local officials say that there is, while the system is strained, that it has not broken and that there is, in fact, medical equipment and ventilators. What are you seeing?
So today I'm speaking to you from my hospital, which is an NYU Langone affiliate in Nassau County, where we're now having the peak number of cases. We have enough personal protective equipment. I'm actually carrying some, and I've been using it all morning before I came to speak to you. We have almost double, if not more, the number of intensive care units. When I left work here on Thursday night, we had 7 intensive care units. Now we have approximately 9. We normally take care of only 3. That tells us that there's a huge increase in the critically ill, and those patients are almost to the last patient on mechanical ventilation. So that means that these patients are on life support, needing intense monitoring all of the time on devices to breathe. We have used all of our mechanical ventilators, which are formerly for that purpose. We have used what's called non-invasive ventilators. We have used all of those, which are converted for the purpose. We have now additional ventilators. We obtained 30 sometime before the weekend, and some of them, I'm informed, have been donated by the United States military, and they do all the work that I need for my ventilators. So there is no patient here that is not getting critical care to the level that they need. But this is almost 300% the usual capacity that we see.
So given the rise in capacity that you're seeing, the number of people who are coming in and the forecast, which is that it's going to be bad throughout this week, there's been a lot of focus on hydroxychloroquine. The president, of course, has been talking about it. Governor Cuomo suggested that there's been anecdotal evidence that it's working. What do you make of all the focus on hydroxychloroquine, and where do you stand in terms of all of the talk about whether it should be used, despite the fact that there are no mass studies of it?
Right. Great question. I'm using it on all my critically ill patients. Every patient here that becomes critically ill gets it day 1 through day 5. And the data, I know the data is from the south of France. All it has shown is a very definitive reduction in viral load. We know that the less virus you have, the less immune response you're going to have. So the projection is that is going to make the injury to the lung less. We don't have the facts because we're not waiting 3 years to do tests and find out what happens. We're just using it. Do I know if it's making my patients better? I have no idea, because the patients are severely ill and we're giving them many other strategies as well. But some of them are responding. So it's not a treatment I want to withhold. And I kind of agree with the president that this is a drug, the Plaquenil, that's been around many years for other diseases. We know its side effect profile. We know its interaction profile. So the risk versus benefit weighs out in terms of using it for this disease because there isn't anything else. We're also using an antibiotic called azithromycin, or some places they exchange it with doxycycline. That cuts down on the inflammation. We know that from many other lung diseases. They're also getting high levels of oxygen. They're also getting steroids at different points in their course. They're also getting immune drugs. So all of my patients, I'm in an intensive care unit today with 13 patients, that's just 1 floor above from where I am now. They are all on a combination of these agents, and they are, at the moment, surviving their illness. But the public needs to understand this is an extremely severe illness. I've been in medicine almost 30 years. This is the most severe lung injury I have seen in my career in the quantity of people. Right now, my youngest patient is 40 years old. Last week, we had a patient 36 years old. There have been patients in their 20s. So nobody is immune from this, and we're praying that the social distancing will start having an impact. We are in the beginning of the peak now in Nassau County in New York.
When it comes to the breakdown patients, you mentioned the ages of the patients, and we are hearing some cases of people who are in their 30s, in their 40s. The New York City Health Department has released data about the nature of the patients who are coming in. They're still disproportionately elderly, and the studies suggest that we're still at about around somewhere between 50 and 60 deaths in patients who did not have pre-existing conditions. What are you seeing in terms of pre-existing conditions, and what are the pre-existing conditions that people should be most worried about?
So we're seeing a lot of people who have diabetes, a lot of people who don't seem to have a condition but have obesity, seem to have more of a difficult time. We're seeing patients who've got underlying health conditions. They have a kidney disease. Maybe they're on immunotherapy because they have some kind of chronic malignancy. Let's imagine a leukemia or a lymphoma of that nature. So there are people who have very serious health conditions where we are seeing this illness that makes sense that they could be more vulnerable. But we are also seeing patients who've not had any significant illness and are coming in with the most extraordinarily degree of severe illness. So it may be we've not diagnosed them. They could have prediabetes we didn't know. They could have a health condition we didn't know. But this is not a benign entity. And we have had some 24-year-old patients come in extremis and not survive. So those are not my patients, that is say. So we take this very seriously. We also want to say we do have the most advanced critical care. NYU Langone, like all of the New York hospitals, is highly experienced in critical care. The United States does train doctors in critical care to a very advanced degree. Our patients are getting everything they need. There is no shortage. If we had one patient with COVID or we have 100, they are getting the same level of care that we would do because we've just made it work. The fact that I'm even speaking to you today is I've come out of a 10-year retirement from critical care to help because there are not enough current critical care specialists to do this. But we do have people that are trained and experienced. It's just the capacity and the number of patients that's very, very high and very unusual.
Dr. Ahmed, one of the questions that's been asked is whether the number of cases and deaths are being actually understated because it's possible that a lot of people are not coming into the hospital. And when it comes to the hospitalization statistics, by the time people get to the hospital, do they tend to be more severe, or are people coming in with light symptoms at this point?
So you're asking a really smart question. I think the fact is we really don't know what's called the case fatality rate. That means if you take 1 million people that are infected, how many of them will pass away from it? We don't know that because we don't have the population study. So the mortality rates that we have are much higher than if we had all of the data in the background. By the time somebody is coming to a hospital, they've selected out a more severe illness. But remember, I am seeing maybe 1/3 of the patients in the hospital who are critically ill. There are 2/3 that I will never see because they'll go to a ward or an observation and they'll go home because they get better. And then there's a huge quantity that don't seek medical attention that are also getting better. So we are seeing the very sharp edge of the tip of the iceberg, but that is also startling because the injuries are severe to the lungs and the numbers of these patients are very high. And this is not happening to people who have previous lung disease, and that's the only reason, or previous asthma. We do have those patients. They are vulnerable, but that's not the only reason. There's people with normal lungs that are becoming gravely ill.
So, Dr. Ahmed, there's been a lot of pressure to move toward reopening of the economy. There's some models showing that the flattening of the curve has begun. There's been talk about what exactly happens beyond the flattening of the curve. Presumably, the purpose of flattening the curve was to not overwhelm the healthcare system. Let's say that, God willing, we don't actually overwhelm the healthcare system.
God willing.
We've also been told that this virus could be seasonal, and that it could come back in the fall. There could be a second wave. Well, if you were a public policymaker right now, aside from just telling people you need to stay home, shelter in place, social distance, longer term, after this curve goes down, what would you be recommending?
So actually, I think it's not necessarily longer term. It's what we should do immediately. And I have to say the president's public health instincts on this pandemic have been exceptionally good. The travel ban on China cut down international case transmission by 80%. And the United States was the first to do it and very criticized, and that has bought us time. He was also very prescient on cutting out travel from Europe. The only regret I have is he should have done it a month sooner, but he did it. And now, similarly, the case for quarantine. I actually believe in something called tailored quarantine that the president has sort of mentioned and has been shot down in flames for. I would like to see more restriction on certain areas where there's intense outbreaks and less restriction on others. Now, that is a very difficult public health and economic decision. But I think that that could be possible. It makes sense to open up areas of the economy where there is less population density, less evidence of outbreak, less penetrance of the virus, a lot of things that we know. We know New York, there's a 34% penetrance of the virus, according to Dr. Birx, which is that 1 in 3 people that comes for testing is infected. Some states is as low as 8%. So you can use that data to decide where to open up the economy and also what. Open up the economy where people can work remotely. That should be priority number one. And people have to still engage in wearing face masks. Even speaking can transmit this virus. 50% of the time it's transmitted with asymptomatic. Hand hygiene has got to become imperative. Maybe we need restaurants with half of tables. Maybe we need theaters with every other row not occupied. I mean, we just don't know how we're going to have to modify, but we cannot stay immobilized forever, though this period that we're doing in New York is going to have huge dividends in the coming 1 to 2 weeks. We're going to see a relief from this kind of intense pressure, which, by the way, we're handling. NYU Langone has handled it incredibly well. We've not had to split a ventilator. We've not had to deny anybody care. And everybody that gets on life support gets it to the last day of their life that is decided by their disease process, not by lack of resources.
Well, Dr. Kanta Ahmed, pulmonologist, intensive care specialist, currently treating COVID-19 patients at NYU Langone in New York. Really appreciate your time and really appreciate you doing what you're doing, taking care of patients out there. The insight is terrific. Thank you so much.
And Ben, thanks for reminding the public that they have a real role to determine our outcome in this. That's so important. What you're doing is saving lives that we really want to be saved.
Well, I really appreciate it. Thank you so much. And you're doing a lot more than most other people are doing at this point. So appreciate
and Ben,
the time.
Let me just say, Chag Sameach Pesach. I know that's coming.
Oh, you too. You too.
Yeah.
I hope you enjoyed that clip from The Ben Shapiro Show. If you did, go ahead and hit the subscribe button so you stay up to date on all of our future content.